seminar. I'm happy to introduce Professor Priya Werahera today. She's an associate professor of pathology and bioengineering at the University of Colorado, Denver, in Anschutz Medical Campus. He received his PhD in electrical and computer engineering in 1994, and is a renowned leader in clinical translational research in prostate cancer diagnosis and therapy with over 20 years of experience. His main research interests include biomedical imaging, optical spectroscopy, bioinstrumentation, computer modeling, and nanotechnologies for cancer diagnostics and therapeutics. He's a member of the University of Colorado's Cancer Center and a senior member of the IEEE. Today, here to talk about the optical biopsy needle based on fluorescence spectroscopy from prostate cancer diagnosis, for prostate cancer diagnosis. So, welcome.
Thank you for that introduction, Ariel, and thank you very much for coming. And I hope you will learn some things today about the disease and then how you translate basic physics, engineering into diagnose diseases. And the techniques we're going to discuss today is in general applicable for all types of cancer, and I have personal interest in cancer diagnosis and therapeutics. So I'll give you an overview of how serious of a disease is this. And this particular work is been inspired by Professor John Daly here. He's a senior member in the community here, and he initiated the conversations some 12 years ago. Really came to the campus and kept begging, you need to develop optical spectroscopy based devices for cancer diagnostics, and that's where the initiation and inspiration came from, and he's still with us in the group working hard, and so it's nice to have him here also today. To get you started on this one, basically most of these cancers, when it is confined to the particular organ, your outcome is very good. But once it is metastasized, gone to outside the specific location to distant sites such as your bone, and your solutions, your options are very limited, and early detection is the best solution, of course. We have 1.6 million new cancer cases that will be diagnosed this year in the United States. That is all cancers, men and women, and about over 500,000 will die from cancer, and then 1 in 4 deaths in the United States is attributed to cancer. That's in general. And of course, my main interest is in prostate, but here is the male versus female distribution. We call the big four, that is the breast, lung, prostate, and colorectal cancers. And and the breast cancer numbers are about 220,000. That is the number diagnosed, and the death rate is close to 40,000. And in case of prostate, we're going to diagnose about 240,000 men this year with the disease, and then about 28,000 of them will die from this disease. So it's a critical thing. And the prostate cancer accounts for about 20% of all male cancers, and second leading cause of cancer deaths. Every year we screen about 1.2 million, a little over a million patients, because they have been indicated for prostate cancer, which I will describe later on. And as I said, 240,000 new cases this year, and then 28,000 will die from this disease. The cost, initial screening is about 2 to 3 billion per year. That is the diagnosis of the disease, and then the therapeutic side is about another 3 to 4 billion, surgery, radiation, you name it. And it's a big, big problem. But with prostate cancer, there's a little dilemma. We know most of these people, as they get older, is going to get prostate cancer. When you are 70 years old, 70% chance, 80 years old, 80% chance. When you are in your 10th decade, 100, getting close to 100, you're almost guaranteed to have prostate cancer. The question is, are you going to die from it, or are you going to die with it? That's, if you look at the epidemiological data, autopsy studies have confirmed that more men die with this disease rather than from it. So the question is, you are sticking needles and then you're picking up cancer, then you're sitting there like, okay, what do we do now? Do we need to treat this patient? Will the therapy benefit the patient, or can we leave him alone? So there are no markers, there are no magic, things to identify these people. We're looking at people coming out of the airport, especially men, and trying to figure out, okay, who's going to get, but not going to die from it. It's a very difficult question to answer. So the prostate is a walnut-sized gland, in between, located between the bladder and the male penis, and it has several functions. Three main functions are: it helps to propel semen fluids into the the womb during the male orgasms, and there are special muscles. Now, this is one of the things you need to understand compared to the breast. Now, the breast have fatty tissue, and I'll explain why this works in our advantage. In the prostate, it's all muscle. Now, how many of you know the fatty tissue fluoresces? Do you know that fatty tissue fluoresces? So if you try to develop a spectroscopy-based technique for breast versus prostate, where there's fatty tissue in breast, there's none inside the prostate, where would you go first? To the prostate, because it becomes a confounding condition in the breast. If you try to measure the fluorescence content, then because this fatty tissue is fluorescing inside the breast, it becomes difficult to quantify your data. Whereas in the prostate, we don't have that issue. So it works into our advantage. The second function is it aids the sperm motility and the survival. It provides several prostatic secretion, and then this PSA, prostate-specific antigen, which is a protein that we use to diagnose prostate cancer. In the normal men without any disease, prostate cancer, they have undetectable levels, less than 1 nanograms per milliliter in the circulating blood. If there is prostate cancer, then the blood vessels break down, and then there's a high amount of PSA creeps into the blood, and that is an indication for cancer. Always not 100% accurate, but some indication, and that is one of the reasons we screen patients when the PSA go above 4 nanograms per milliliter. And of course, the third function is it also controls and prevents urinary entry during ejaculation. Of course, as I said, the bladder is sitting on the top, and then during sex, you want to make sure that corner is tightened up, close. The sphincter seals the bladder, preventing urinary entry into the urethra, so that the complex valve systems will open up. What you call the seminal vesicles will open up and move the sperm into to the womb. So those are the three functions. Here is the rates, and the U.S. African American population yet at a very high risk, and the Caucasian population next, and based on ethnicity. And this is not a big problem for the Asian countries, Chinese, Japanese, populations, very low rate. But mostly this is a Western hemispheric related disease. We don't know why. Could be diet, could be the ethnicity is a factor, age is a factor, it could be genetics, and it could be because some Asians eat less meat-based product, mostly fish diet, soy, etc. But here it's all red meat. None of these are confirmed, but these are basically risk factors, we think. This is the gross overview of the prostate, and here is the cancer. You can see that this is a very hard area. If you're a mechanical engineer, the tensile strength on this area is very high compared to the normal. So this is the gross overview of the cancer there, right there, that white creamy area. And if you look it under a microscope, the normal cells have a very, now just like the breast, the prostate is have glands, it secrete prostatic fluids. Okay, and the normal cells have two cell layers, the basal epithelial cells and the secretory cells. So both are present in the normal cell, and then the rest is all fibromuscular stromal cells. And these cells secrete prostatic fluids. Now, what happens is when you have a tumor, instead of cancer, the basal cell layer is no longer there. Now, if you look at this picture, it's difficult to say which one, which part of the gland is cancer, but if you do a special staining for basal cells called the pink cocktail, you can see the top portion here, that's the basal cell layer. Obviously, that is normal glands, and that is nothing here, so that's, cancer. So the second layer down here, that's, that gland is cancer. So that's how you, identify cancer cells. We have a grading system based on the glandular architecture. If the glands are, these are still cancer, but if the glands are very compact, tightly packed, it's called pattern 1. When they begin to sort of loosen up, number 2, number 3, you can see the glands itself begin to go crazy. By the time you come to pattern 5, there are no glands, just sheets and sheets of free floating cancer cells. So pattern 4 and 5 is horrible disease, and it correlates with very bad prognosis. If you diagnose in biopsy cancer, first thing you want to know, does he have high-grade disease? So high-grade means pattern 4 and 5. Now, due to early screening, we don't see any more these patterns 1 and 2, which have very good prognosis. About 65 to 70% of our patients are pattern 3. So, this is Dr. Gleason. He's the one who came up with this grading system, which is the best for any cancer. No other grading system compares with this system. It's very difficult to beat the Gleason grading system. So what we do is when we look at the biopsy, you express this as a sum. You look at the most dominant component, and then you look at the second dominant component, and then you add those two. If there's a pattern 3, the most dominant, little bit of pattern 4, we call it a Gleason 7. If you don't see any other patterns, you add these two, 3 plus 3, and call it a Gleason 6. So most of our cancer patients are Gleason 6, about 65 to 70%. Again, the grade is an important prognostic variable. If you know high-grade disease, we can predict what is going to happen to the patient. So, so Gleason 1, this is a Gleason 1 slide. As we can see, still cancer, the glands are very tightly packed. And pattern 3, now you can see there's space between glands, and the glands are going to take some, unique shapes. This is pattern 5. No gland boundaries, just cancer cells, sheets and sheets of cancer cells. So when I was first starting in this area, I was challenged by the people in the medical school to say, can you design a computer model to digitize prostates? I was doing a PhD in computer networks, and then I took over this project as a side project and designed a computer program and the methodology to convert any kind of prostate specimen into the computer model. So we came out with a method. So you take this whole mount slides, and then you create a map from these cross-sectional information. Then you use some extrapolation and interpolation algorithms, and then you can design a computer model of the prostate. So each patient who undergoes surgery at our institution, we now have a method to digitize its prostate and keep a replica in digital domain. Now you can do fancy work with this thing, and here you can see the blue is the urethra. There's a pattern 3, a large tumor, and a little bit of pattern 4, a high-grade tumor inside. And you can do a lot of computer modeling work. And here is another view of one of our patients. These have 4 different patterns, and they are all color-coded. And if you want to study your biopsy protocols, your success rates and things like that, you can do using these models. Here's another view, a cross-sectional view, and here is a 3D shape of the tumor. And this one have a high-grade pattern 4, and then pattern 5, a little bit of pattern 4 here, and then pattern 2 there, Gleason pattern, the grades. And the disease is also multifocal. Prostate cancer, almost 2/3, maybe even 75% of patients present with multi-lesions inside the prostate, not a single tumor, but more than one tumor. And here also, some of these things can be coming out of the prostate, like the capsule, penetration, which is very bad disease. So if you remove the layer, you can see, In this patient, you have about 5 separate lesions with multiple grades. And so let's get into the diagnosis part. As I said, the screening is based on PSA, a blood test, simple blood test. If the prostate-specific antigen level is above 4 nanograms per milliliter, you bring the patient for a biopsy. Or we also do a rectal exam, because you can palpate the prostate when you put the finger from the rectum. What we're looking for is the asymmetry. You kind of like, put the finger around and see whether there are bumps in the, where hard nodules, in the prostate. And if you feel it, then you call it an abnormality. And then you, again, ask the patient to come and, take a biopsy. And still, the biopsy is still the gold standard. You have to stick needles into the prostate, of course, randomly, and then pick up tissue and then send the tissue to the pathologist, and the pathologist will say, oh, this patient has cancer. Only about 50% sensitive, and as I said at the beginning, many of these cancers detected is never going to be life-threatening. So we have a little dilemma there. Okay, we picked up cancer, now what are we going to do? So this is how it's done. The patient is in the sideways, and now we, of course, give anesthetics, local anesthesia to the prostate. 10, 15 years ago, none was given. You just stick needles into the prostate, and have a very less nerve bundle concentration. So, patient usually doesn't have much complications, Tylenol, antibiotics probably. And here is the ultrasound probe, and then there is a little needle guide in the probe, so you can shoot the needles through here. If you look at here, 70% of the cancers are in the posterior zone. So here is the anterior and here is the posterior, the area region close to the prostate. Almost 70% of the cancer comes in the posterior region. Now, but of course, that doesn't mean there's no anterior tumors. But that is the region we biopsy. We take like 10 to 12 biopsies, very random. I have no idea what you're picking up. You just stick and you're hoping you will hit it. And so on an ultrasound image, you can see the prostate, the anatomical boundaries, nothing else. It doesn't tell you which tissue is cancer or not. And you can literally see the needle firing, and and then the biopsy needle looks something like this. This is the BARD 18-gauge biopsy needle, not a smart needle. It's just a with a firing mechanism. And so the treatment options, of course, you get a whole array of treatment options. One is called watchful waiting, do nothing. If you have small tumors anteriorly located, less than 5% core involvement, you took 12 cores and 1 core came a little bit positive for cancer, you might say, okay, Mr. Smith, go home and wait, come back, sometime later. And also active surveillance, this is a little bit more involved, where you routinely regularly bring the patient back and monitor the PSA, and also take some biopsies on the location that where the tumor is, to see whether it is growing bigger, getting aggressive. And this is now, few years ago, 5 years ago maybe, this was not an option, treating just the cancer lesions. So I did some proof of concept work, and where, I developed a technique to screen patients with low-risk disease, taking a large number of transperineal biopsies, and showed that about 30% of our patients are eligible for what you call the focal therapy. Here, instead of whole gland therapy, you just go and just treat the lesions, the cancer lesions. Why do you want to do that? Whole gland therapy, something like this one. Surgery, external beam radiation, brachytherapy, where you leave radioactive seeds, they have very bad side effects. Erectile dysfunction, incontinence, it's a quality of life issue. Now, nobody's going to die because they remove the prostate. It's not an essential gland. It's a non-essential gland. But the quality of life issue is a big deal. So this whole gland therapy, set of therapies are only warranted if this patient is going to die from this disease. So because of that, we know a certain group of patients have the low risk for, death by prostate cancer. So you can just go and treat these lesions, and most of them can be actually left alone. The last batch, of course, is for advanced disease, hormonal ablation and chemotherapy when the disease is beyond the prostate capsule. It's one of the favorite places to metastasize is the bone. Bone mets are very common. And that when you come to that stage, your days are pretty much numbered. And so what are the problems with the needle biopsies? As I said, there are no imaging devices right now to identify cancer, prostate cancer. MRI, CT. MRI shows some promise, but it is still debatable. CT scans and PET scans, and none of these are going to identify cancer. So you're basically taking biopsies without any knowledge of the underlying tissue morphology. And so they are consequently subjected to very serious sampling errors. So because of that, the clinical detection rate, now this is not the sensitivity or specificity, nothing like that, just by overall detection, when you look at, broad spectrum, we only pick about, 25 to 35 patients. That's how much cancer we pick up. So that 240,000 number that we are going to pick up this year, that is after screening 1.2, 1.3 million patients. Now, what about the ones that we did not detect? Do they have the disease? What happens is, of course, up to about 50%, maybe a little more than that, have the disease, and that because we are not using a smart needle, we are missing them. So they're going to come back 6 months later with very advanced disease, which is problematic for us. So if you look at this picture here, so these are simulated needle biopsies. We use the computer modeling technique. I have given a cross-sectional view here. You're sticking these needles here, and you're not picking up anything. So if you remove the outer layer, you will find the large tumor is stuck in the middle, never hitting with a biopsy needle. So this is one of the very common occurrences in the clinic. So we know about 50% of those, the so-called clinically important cancers, are missed. And so the challenge is to get accurate grade, accurate stage of the disease. Stage is how widely spread this disease is. But these blind biopsies are not going to do it. So you need a smart needle. So that's where optical spectroscopy comes in. So the light, the photons interacts with biological tissue in a number of different ways, and the tissue can fluoresce. A certain spectrum of the energy can be absorbed by the tissue, the proteins. They scatter light. So these things are depending on the molecular composition and the cellular morphology of the tissue. So when the light interacts with tissues, there is a disease there compared to the normal areas. There's going to be some differences in these mechanisms where you can actually, if you can quantify the data, you can pick these things up. So if you have a malignant growth, so these changes in the molecular and the cellular level alters these fluorescence, absorption, scattering, and then if you can quantify that data, you can pick up the disease. So there are a number of diagnostic tools available in this area to get the pre-disease and the disease status. And the most common ones are for the so-called the surface cancers, skin, esophagus, not necessarily for these internal organs like prostate or breast. So, so when John came to us, that was his thing, saying we can develop something for the prostate because they already have things for skin, bladder, colon, etc. But why not try to do something for the prostate? The problem, of course, is the disease is heterogeneous, and then also the physiological inaccessibility. This is not, you had to go through the transrectal approach, and trying to design some optical devices to do this is not all that straightforward. And when you are designing some of these things, you need to understand this interference for the optical signals. The two common ones are blood and water. And I'm pretty sure most of you have seen these pictures. And in the UV range, you need to pump certain amount of photons to get a signal back. but the oxy and the deoxyhemoglobin absorb most of it. And in the infrared range, it's the water. The water due to absorption due to water picks up. So there's a small window from, say, 600 to 1,000 nanometers where you can get, no absorption. Mostly it's largely scattering. But, within that range, if you go from the UV to, say, visual range, the optical depth of penetration change maybe from about 300 microns to about 1 centimeter. So these things, so when you're designing an optical diagnostic tool, this information becomes very handy. So the fiber optic sensors are pretty well established. You can use a fiber bundle like this to send light photons to the tissue, and then you can have a collection fiber to pick up the signal, and then you can analyze this data. So as I said, our main interest is in the fluorescence signal, and there are endogenous fluorophores in human tissue. These fluorophores, namely NADH, FAD, tryptophan, collagen, they are common, they are abundantly available. So if you excite the tissue at specific wavelengths, these things fluoresce. Now obviously if there is a malignancy, the amounts begin to vary. So the excitation is largely close to the UV range from 250 to about 450. The challenge, of course, is this is a very weak signal, so you need to have good detectors to get a good signal to noise ratio. And so before moving into actual tissue, we did a cell line study, cell cultures, in vitro studies, and so these DU145 malignant cells we compared with the ER, the epithelial normal cells, and we used a laboratory fluorometer from JY Horiba, and we measured, and then we could identify some of these fluorophores, tryptophan, NADH, and if you look at, obviously there's much more larger levels, higher levels here. In the normal cells, the concentration, they had to be compared on the same basis, of course. You don't see the collagen in this one because collagen is a structural protein, so now some of these things are not present in the cell lines. But of course, collagen is also an important classifier. So this is the prototype biopsy needle, and so you have your biopsy needle. There are two parts to it. There's an outer needle and an inner needle. The inner needle have an area where you can actually collect the biopsy core. Now, if you really wanted to put a sensor at the tip, you have to bring the fiber underneath that little specimen notch. So this was a little too much for John and me. We discussed this, how are we going to address this is a mechanical engineering problem. Luckily, he's in the mechanical engineering department. The CU gave us some money, and we assigned this to a group of mechanical engineering students as their senior design project. Design re-engineer the inner needle so we can bring this fiber to the tip. So, so they did a fantastic job. Of course, Mr. Edward Jason here, he's now, he was in the same group. Now he's working as the project manager for this study. And so they, went through and came up with drawings, and and then of course they came up with several configurations: 6x1, 8x1 fiber configurations for the probe, and of course they did some ray tracing. Now the challenge was, of course, it's a needle, so it has to be cut at an angle. Now why this is so critical? If it is a flat probe, or everything comes from the fiber will come out of the probe. The laws of physics, the Snell's law, if it's an angle, light begins to bend. Now, especially coming from fiber, which is approximately the refractive index is glass into air, some of them are going to be reflected back. So the angle is very critical. So, and the other thing is we also want to maximize placement of this fiber so we can get the fluorescence signal. As I said, it's a weak signal. So they did some ray tracing and used these refractive indices for glass and air, and then And they said, okay, the optimum angle is 40. The problem is, if you cut it at 40, for a biopsy, when the needle fires, it has to cut through the tissue. When you have this shallow of an angle, it doesn't cut properly. You need a much more deeper angle. So now we are getting into the areas that you guys are very familiar with. So we look at the critical angle. We calculated using the Snell law, and we use now fortunately for us, we are inserting this into biological tissues. Obviously, the refractive index is closer to water. So we use those numbers. And then the issue, of course, is how much power we need. What angle, so you can use the Fresnel equations and figure out the numbers. Around about 60 degrees, you get most of the losses. You can keep it under 10%. But once you go beyond that, then they increase exponentially. So after all of that haggling, right now the needle angle is set at about 60 degrees, due to all the restrictions. And the biopsy gun is a spring-loaded mechanism. Any questions so far? It's a spring-loaded mechanism. So of course, when you press the button, it fires, and then this put up a lot of stress into the whole overall system. So they measured, how much the force is there, especially when the needle fires and then it comes to a complete hold. That's when all of this force is about 500 newtons comes into play. And now, of course, you need to make sure the structural integrity of the needle is reliable and sound. So they did a FN finite element analysis, and they found the most stress is at the back end of the needle. And the maximum stress was calculated about 153 megapascals. And so with all that information, we have now developed what we call a prototype needle. This unit is actually commercially available. It's a gun. It's a separate gun. So what we design is the optical needle here, the biopsy needle with the optical cables. And this can actually measure, quantify the amount of fluorophores there. Now, hopefully, if this is working properly, we can go and diagnose the disease before we take a biopsy. So this is our old laboratory. This is this dinosaur here. It's a big fluorolog 3 fluorometer, as I said, and we use this to excite the tissue at 280, 290, 300, up to 350 nanometer excitation. We actually captured the prostate tissue in the entire spectrum. And after doing that, we sat down and looked at the data. We thought most of the interesting features are in this range. And the emission was picked up from 295 to 540. There was an optical bench here where we can actually pull the light. This is a xenon lamp, 400 watt xenon lamp, and then the detectors are photon multiplier tubes, PMTs. And so we pull the light signal out, and it goes to the tissue, and then we return the signal back to the detectors. So we use fresh prostates. The reason being, these fluorophores begin to decay very quickly. So all these measurements were done within a 90-minute window. There's been studies using golden hamster cheek pouches to show that if you do this within 90 minutes, the levels you measure is very much similar to in vivo measurements. And so we, look at the fluorescence spectrum. As you can see, there's a tryptophan signal. There are scans of various locations from different patients. Collagen, NADH, they're all available. And we also measured the scattering spectrum. We haven't analyzed this data. Nice thing about the scattering data is we hope it will be sensitive to the grade. Now remember, I said the grade of the disease is very important. So we are hoping the scattering signal can give us, whether it's a high grade or low grade disease. We haven't analyzed this data, although we have collected all the information. But right now we are moving forward with the fluorescence data. And so what we do is you put the needle in, take a measurement, and then we take a biopsy core from the same corner. And then we put ink onto the corner we know we measured. And then the pathologist classifies the first millimeter. Why? Because in that region, all we are worried about is about 300 micron. And so this classification is an all or nothing classification. Biopsy core A, that region, that portion is classified as stroma 95% and atrophy 5. And then the core B is, of course, cancer 25%, and then atrophy 10 and stroma. It's an all or nothing classification. Whether you have 5% cancer or 100% cancer, we call it cancer. It's an all or nothing classification we use. And of course, we did an analysis based on, we subtracted the background, we did the normalization of the spectra. What did we do here? We took the spectrum, and each spectrum is normalized to itself. So the integrating sum is 1. Now, why do we want to do that? One of the things you need to understand is the absolute fluorescence levels have very little usefulness. You cannot come up with a mechanism to say, okay, you know, here is my normal fluorescence level, because within the same patient, it can change. And from patient to patient, that level is not a fixed number. So absolute fluorescence levels are not very good for this type of classification. So what we did was we normalized the data. So when you normalize the data, even within the same patient, you can pool them together, and also from different patients as well. So each one of these curves is normalized to 1 by integrating sum. And when you do that, you get a structure like this, and you can see the benign in blue, malignant in red. And then you can use a classification methods, principal component analysis. We use actually something called partial least square analysis. It's a way of obtaining more refined principal components. If you do the straight principal component analysis, it doesn't look at the Y variable, the pathological data. It tries to optimize, tell the differences in the data set on the X variable alone. But if you use a partial least square analysis, it tries to optimize the principal components by looking at the pathology as well. So you get a more refined set. So we look at 104 biopsy cores with 73 benign and 31 malignant. And we try to look at, remember we were taking at 6 different wavelengths. We try to pick up the wavelength PCs that are not correlated. And we picked up 3 components at the 290 and then 3 at 330. So the 330 is basically tracking tryptophan, and then 350, 2 principal components. And if you look at how these principal components, from the PLS analysis, the first and the second, once you add them, it explains almost over 90% of the variability in the data set. And the first, second, and the third begin to address almost 60% of the pathology, the Y variable. And based on that, we use the principal components at 290 excitation, just 1 wavelength. And we find that the 28 of true positives, 67 true negatives, and then there were 3 false negatives and 6 false positives. This is just all the principal components at 290. So we combine this information in a support vector machine analysis. Okay, here are the ROC curves. Again, you can see the more principal components you can add, the more wavelengths you can bring in, the area under this, get closer to 1. And then we did this support vector machine analysis with a leave one out cross validation. There was a linear kernel and a RBF kernel, both methods. And we can classify this tissue with a 84% sensitivity and 96% specificity. The negative predictive value is also very high, as well as the positive predictive value. What does this tell you? It tells you, like, if you stick this needle, you can tell basically if there is no cancer, which is valuable information. Because most of these biopsies are negative. Large number of biopsies we take from these patients are negative. So that is a big deal. You can actually cut down this number drastically, because now you have a sensor, You take a measurement, you know, oh, this is normal. Why am I going to take, biopsies now? So you're going to begin to, sort of poke around. And so we started a company based on this, a small startup company in Colorado. We got funds from a venture capitalist group. And this is our conceptual system. Now, we have a laboratory fluorometer which have, 400 watt xenon lamp, photon multiplier tube, a large footprint. This cannot be moved to the clinic. So we had to go and figure out what would be the best way to implement this in the clinic, because in the clinic, to do this small footprint real-time analysis, couple of seconds, you need to know whether it's cancer or not. You don't have 5 minutes to do this. So, so we prototyped, this fluorometer. This is from Ocean Optics in Florida, and then they designed based on our specifications. We have 2 LEDs at 290 and 340, which is about 1 milliwatt of power. Has been calibrated to deliver about 5 microwatts. That's how much power you need for this kind of work. You don't need a lot of power to get a fluorescent signal from tissue. And have a custom MAPRO spectrometer in there. And, and then, of course, this is classified as a class 3 laser for research purposes and a class 1 laser for clinical patients. And we also prototyped the biopsy needle. And we have Avantes here, Broomfield, Colorado, and then the TDC Medical in Sunnyvale, California, who has developed the needle and has tested for the mechanical and structural stability, and had to be sterilized if you're going to use this in live patients, and packaged. And then, of course, question becomes, all of this work is done ex vivo. So if you go to a live patient, there is blood, flow of blood. So the question becomes, okay, do you have enough signal-to-noise ratio? Can you still pump enough photons into the prostate to get a reasonable fluorescent signal? So we did this canine model testing, and to see whether there's any kind of interference from the blood, because that's the region, the biggest absorber in there. And we found there's enough signal-to-noise strength. And we also completed a cadaver study. I'm in pathology department. We get about 120 to 200 bodies every year, and we tested the needle in one of the cadavers. So we are now in the first in human clinical trial at the University of Colorado Hospital to test this prototype biopsy needle and the fluorometer. We have received the approval from the Western IRB. We plan to take about 30 patients. And every patient who's going to have prostate surgery, we will interrupt in the middle of the surgery while still the blood flow, the blood vessels are intact, and then the abdomen is open, and then we can put the needle into the prostate and take a measurement and also a biopsy core. And then once the prostate comes out, we continue to take measurements ex vivo as well. The study started July 1st this year. So far we have recruited 7 patients. We have about 27 patients ex vivo also captured. And right now, we are in the data analysis phase. And I'll show you, so this is our OR setup. Eddie and a whole bunch of people, Dr. Crawford, everybody is in there. That's, I believe, is that our fluorometer down there, Eddie? Yeah, that's the fluorometer. And then we have software developed on LabVIEW platform here that runs the whole fluorometer. It takes about a minute, it's about 1 second to do the whole thing, maybe a couple of seconds. So this is the ex vivo patient number 5, and the normalized data at 290 and 340. We were doing this to make sure we got enough signal-to-noise ratio. Now about 12 patients in this group have cancer, positive for cancer in the cores. EV6, we have 20 cores again, but they're all benign. And so we did a partial least square analysis at 290 excitation, pick up the first and the second principal component. EV5 is in blue and EV6 is in red, and then of course that's 10 out of 12 cancer data is in that cluster there. Now that is for 290 excitation, and then of course we can look at the 340. Which is a very weak signal, by the way, and we were not exactly sure whether this will give some data, but then that also actually separate the benign from the cancer and again 10 of 12. So if you put these principal components into a support vector machine analysis or artificial neural network, you should be able to come up with sensitivity, specificity numbers. So to summarize, so we have successfully developed this prototype biopsy needle and the apparatus to diagnose benign versus malignant prostate tissue. And we are using endogenous fluorophores, the fluorophores naturally in the body tissue. We don't need to put any artificial dye or something into the system to work on this one. And in clinical settings, we are hoping this device can give us accurate grade and the stage. The grade is again the lesion grade and the stage of the disease. There are other applications also. You can use, let us say you put the needle in there, you know there's a tumor, and then you can use the same fiber to send a laser beam to ablate that region. So there are a number of other applications. So the biggest issue is, how does this impact the healthcare system? Obviously, it very conveniently fits into the current practice. It doesn't have to make big changes in the current practice. It's a small footprint. They still take biopsies. Only thing is now this is an optical biopsy. It doesn't have to make major alterations. It also eliminates the over-treatment. We are hoping now, we know about 6 men are treated to prevent 1 death. Other 5 could have been left alone. Now, if you sample the prostate with this device and you pick up the grade, the stage of the disease accurately, and then you say, okay, Mr. Johnson, you can go home and enjoy your life, that's really a big deal, and it's a big savings to the system. And also, we can identify patients who will benefit from the therapy side, and also eliminate unnecessary repeat biopsies. This is a big problem. As I said, almost 50% of these cancers are missed during the first visit, and these guys come back 6 months to a year later with advanced disease. From the very first going, we can eliminate these things. Also, the negative biopsies, as I said, that patients who will eventually go on to develop advanced disease, we can eliminate that. And all in all, it's about over $1 billion in savings to the healthcare system. I hope Uncle Sam is very happy about it. And acknowledgement, there's a lot of people to thank for this. And we have 2 teams at UCD and Prostate Cancer Research Laboratories, and then we have the startup company. Mr. Amit Tehrani is the CEO. We have Eddie here, Mr. Jason, he's the project manager, Dr. Daly. We have a whole group of people, Liz Brady and Nancy, for the regulatory purposes. They developed all the compliance requirements for the study. And Dr. Crawford and Paul Moroney are the 2 urologists in the group. They provide all the patients, and Dr. LaRosa and Scott Lucia are the pathologists. And then we also have our postdoc in the group, Leo here, and then this the hospital staff here who would recruit patients and maintain all the paperwork. The commercial partnerships come from Allied Minds. It's a company, VC company in Massachusetts, and Ocean Optics, Avantis, and then TDC Medical. And then, of course, none of this is possible without the patients. We, over the years, since John joined this group, over 150 to 200 patients have been used in this study. And without them, none of this would have been possible. That is one of the advantages being in the AMC campus. So that's it.
With the probe, you can only access one side of the prostate.
Say that again?
You can only access one side of the prostate. So
Mostly the area that you palpate, you can access, if you want to access the apex, there are ways to do that. I don't want to give a very guilty feeling to everybody. If you want to go into the prostate, you can do that too.
So when you say those numbers, 90% success detection, so it's for this side.
Those are ex vivo prostates. So we stuck the needle, we stuck the needle all over the prostate. So that's from everywhere on the prostate.
The needle, so when you're looking at the prostate, if you're looking at, if this is the posterior, so well, you're looking at a man on the side, the back of the prostate, posterior, anterior is here. Most of the cancer, about 80% are in the posterior, and that's the most easily accessible with the needle. So you can access this area, the anterior, if you will. It's just more painful because in between separating the anterior and posterior is the urethra. So it's a little more sensitive as you're passing the needle by there. But you can access most areas of the prostate. It's just some you have a better chance of finding cancers, and the ones that you have less, luckily the ones you less likely to find cancer are kind of more painful and avoidable areas.
Yeah, so the probe goes, ultrasound probe goes here, and then the needle goes here. Now, obviously, you have, they are going at a 45-degree angle. Now, if you want to come to the front, you really have to rotate the probe, and everybody kind of grimacing down there. It's done. I mean, whether you like it or not, I mean, on good days, Dr. Crawford might take 24 biopsies, and I say, why? Oh, I'm having a good day today. Good day for him, not necessarily, but.
And if you were saying, you'd also be right if you said that you can only measure one site at a time, right? So the sensor on the biopsy needle is just at the tip. So when you're in there and you're pushing the button and getting fluorescence data, you're just looking at what is adjacent to the tip of the needle. So
But you can measure all the way during an insertion.
Right,
So you
right.
can
So
get
you
profiles, which you can't get with a needle, conventional needle biopsy. You can only take one. So
Yes?
Is there right now any correlation with the PSA data?
We didn't try to do that because PSA is already established as not a very good marker, because patients under 4 nanograms per milliliter have cancer. Patients over 4 nanograms per millimeter have no cancer. It's sort of like it's just not your classic litmus test. So we did not correlate this data with the PSA because this is sort of like different things. Would be nice, but I don't think the PSA have that kind of accuracy. That's the problem. Just because you have an elevated PSA doesn't mean you have cancer. That's why we have to have a smart needle. Now, obviously, if you have high PSA, we'd like to biopsy you. But, sometimes you have benign disease. As you grow older, your PSA is going to increase. So you have to do what you call an age-adjusted PSA. So there are a lot of things comes in, but PSA is, if you read the recent news, they don't encourage screening anymore. So that tells you much about the PSA. Yes.
well, the trauma can affect PSA levels, right? In other words, you have a physical exam that can affect
Yes.
for a short period of time.
Yeah.
PSA level.
You talked earlier about an issue you have with conventional biopsy needles is the sort of randomness and where the biopsy is taken from within the prostate.
Mm-hmm.
Do you have that? Do you avoid that issue with this somehow?
No, this is still invasive. This is still invasive. So what we're going to do, actually what we're hoping to do, is instead of, taking a biopsy, you still go in there. Let us say you come here and then you kind of like scan through that line. We can have multiple sensors. Like we are now designing a probe. Instead of a single sensor, we can have like 3 sensors on the side. So you can actually measure maybe 1.5 centimeters in 3 locations.
You would sort of get an averaging
Correct.
along some path.
Yeah, and then if the disease is there, now it changed the game plan. Now remember, right now, the urologists take the biopsy, they send the biopsy course to the pathologist, and he or she says it's cancer. Now, when you are in the clinic, if you know there is cancer, now you can go and begin to sample around it. What does that tell you? The size of the tumor. If you're going to hit around, it kind of tell you, oh gosh, this is large. I mean, that gives you an idea about the stage of the disease. And then if you take additional samples, now let us say, I told you the grade is a very important thing. You want to know whether there's a high-grade disease, why it correlates with the prognosis, the outcome. Now, most of these biopsies comes as Gleason 3+3. But when you do the surgery, and when you look at the surgical specimen, voila, there is a hidden 4 component that was never detected. at the biopsy. So by having this, knowing that, or by targeting the regions for, positive for cancer, you are minimizing the sampling errors, and also you are getting accurate information on the grade and the stage of the disease, which is for therapeutics.
Thank you.
Thanks, John. Yes?
So what is the time frame for the clinical trials to FDA approval?
Say that again.
FDA approval, clinical trials, how long?
This is a device, unlike a drug. So this can be fast-tracked. You design what you call a pivotal trial, meaning you say, okay, it's a multi-center trial with 200 patients, randomized. Some of them are going to go with the standard needle. Some of them are going to go through with the smart needle. And if we show that the people who went through the smart needle path, we picked up close to 50% or in that range, whereas the standard needle we know is about 25 to 30%. That's the nod for the FDA approval. So unlike a drug, you don't have to go through phase 1, phase 2, phase 3. No, this is a device. They are biopsying already. This is a very well established device. All we are going to do is augment this fluorescence, and then we specifically kept the lasers out of the picture. Because when you say laser, there is a Christmas tree in the FDA that lit up, boom, not a good word. So we use LEDs. Even that one they classify as, laser, class 3, class 1 lasers. But so we kept that in mind. We understand the difficulties. It's like, why bang the head on the wall?
And we also have a nice position because this is the standard of care in prostate cancer diagnosis, needle biopsy is. We're lucky in that we have an adjunct technology, so we're not completely replacing the needle biopsy. We're just kind of piggybacking on it, if you will, where we just, without the fiber optics, the device performs needle biopsy just the same way your standard device does, and we're just adding the extra capacity of giving the surgeon information or an indication. I can't give a true indication of cancer or normal. I can't make a diagnosis, but it can say whether or not the tissue adjacent to the needle is suspicious or suspicious of being cancer, that is. So, and then that's what and for the FDA as well, we're also, we're in a good position because in order to get our device through, we just need to prove equivalency with standard core biopsy needle for prostate cancer diagnosis. And then, of course, the safety and everything. But in terms of the fluorescence, the FDA actually does not allow at this point diagnostics solely based on spectroscopy for this type of application, just like they do for skin and esophagus and all these other cancers. They do allow you to say, this is suspicious, I'm going to take a biopsy, and the pathologist is going to look at it to make the diagnosis.
So still the human interface is
In
maintained.
that point, that we're not trying to say that this is going to be the be-all and end-all for cancer diagnostics.
So similar work has been done for the breast cancer, and the sensitivities, if you exclude the fatty tissue, it's about 75-80%, but once you include the adipose tissue, it drops to about 60-65%. And a group in Nimi Ramanujam, I don't know how many of you recognize the name, and she has done this work at the Duke Medical Center. It's already published. One of the problems, of course, as I said, in the case of the prostate, this is all muscle. So the fat tissue there's fat tissue outside the prostate because the connective tissue, you can find fat, but inside the prostate, it's all 100% muscle. So it worked very well for us.
So this referring Professor Werahera.